Hi, I'm Dr. Karan Chanchlani. I'm a clinical and radiation oncologist at Manipal Hospital Baner. Let's talk about radiation therapy and how it is delivered. So, radiation involves basically high energy X-rays or photons as we call them. There are various energies, and there are sometimes we use particles like electrons and protons also. These are released in the form of rays from a highly sophisticated device like a medical linear accelerator, and it requires a very robust planning before delivering any treatment. This planning actually starts in the OPD itself, like choosing the correct patient and then deciding the intent of the treatment. Close to 70% of the cancer patients will require radiation at some point of their journey against cancer. Some of them are curative, a few of them are palliative intent treatments. Curative intent treatments require higher doses that are delivered over a longer time interval with more fractionation or more number of sessions as we call it, and thereby allowing maximum cell kill. Palliative intent treatment on the other hand involves a limited dose, just enough to control the growth or the tumor at a site which is causing extreme symptoms like excruciating pain, bony pains, risk of bony fractures, brain metastasis, spinal cord compression or compression of great vessels in the mediastinum or sometimes the airways. So these are few indications of the palliative intent treatment. Your oncologist is the best person to decide which type of treatment is required for you. Once we decide the intent of the patient in the OPD, and we are depending upon the general condition as well as some specific parameters, depending upon the site that we are treating, we decide the total dose to be delivered, and then it involves the process of planning. For planning, it requires fabrication of individualized immobilization devices depending upon the site that we are treating. So this is one example of a head and neck immobilization device. These are thermoplastic casts. Similarly, we have alpha cradles or backlogs depending upon the site that we are treating. Once the immobilization is done, we acquire CT scan, a basic CT scan of the area that is to be treated. This is required not just for exact target delineation as well as for calculating the total doses to various organs at risk as well as to the targets that we are delivering, thereby achieving personalized doses for the given patient. We sometimes require additional data from the PET scans, from the MRI, and we fuse it to the planning CT scan that we acquired and delineate our targets and organs at risk. So once we acquire the planning CT scan of the desired part that we are treating, the patient can go back home and the planning on the computer starts. This is our treatment planning station or treatment planning system, TPS as we call it, and we sit on the targets data set and draw the target volumes. We also delineate some structures which we want to reduce the doses to those structures. So typically this is our target. We sometimes use additional information from the MRI. We fuse those MRI scans on the target CT, and this helps in better visualization. So once these targets are delineated, this is an example of a brain case and this is an example of a prostate. Sometimes there may be multiple targets. So this is our primary prostate target, wherein we intend to have a higher dose of treatment, and this is our elective nodal volume, wherein we can reduce the lower doses in order to reduce the side effects. So depending upon there are various guidelines which we follow for various sites, and depending upon the individual case and the gross tumor burden and the potential spread sites, these dose levels are decided. After which we hand it over to the radiation physicist, and he then sits around with the field arrangement, or these days we have this arrangement that we can see as a complete arc in which the machine can move around the patient in all 360 degrees and thereby modulating the intensity at each angle and delivering the most conformal dose that we can see over here. So I'm putting on the high dose now. So this is the high dose region that we are covering the prostate along with some margin, and then we are delivering this dose to our prostate, and this is our low dose region, which is covering the elective target volume with some margins, and thereby still we can see most of the critical structures like the urinary bladder and the rectum in this case are fairly spared from the side effects of the radiation. So we typically have 2-3 plans in our library, like we can see over here, and we select the best appropriate plan for the given patient. So this is the level of individualization or personalized medicine that we go. For every such case, this exercise is done, and once the plan is finalized, we export this plan to the radiation machine, wherein we'll see how the patient is treated with that given plan.